Thank you very much. First, when Costas sent me the program and I saw the session, and I saw that it's a deformity session with 3 top deformity guys, and I'm supposed to close the session. I thought he was joking. I thought it was a joke. So I called him and I realized this was not a joke. So I had to prepare a pretty defensive talk about MIS. And the first thing I did is I took the liberty of changing the title of my talk. It's not MIS versus open. This is not the question. It's about if there is a role for MIS surgery in deformity correction. So one should think about what you want to achieve. Is it about sagittal balance, colon balance? Is it about decompression? Is it about creating a biomechanically stable construct? So there are many factors that can affect MIS surgery, such as surgeon experience, what you have in the theater, what kind of pathology you have, what kind of patient you have on the table. So it is a matter of perception of what is deformity. Is this a minor deformity? Of course, you can treat this in a MIS way. But if you have a patient like this, an 86-year-old with a major scoliosis, this is another issue, or a slip like this. So as Costa said in his talk, is this MIS? Is sparing the fascia and the muscles, is this MIS? Putting thousands of wires in the back of the patient with an open wound. So I'm trying to show you from my point of view which patients might gain from an MIS procedure in deformity surgery. And for me, there are 2 kinds of patients. One of them is like this. This is an 80-year-old patient with mechanical back pain and right-sided femoralgia and burning sensation. Had right hip replacement, right knee replacement, left partial replacement, prior decompressions, fusions, blah, blah, blah. Thousands of problems, is not functional. She has a progressive kyphosis. She's unable to stand more than 30 minutes, is unable to walk independently. And these are here images that show severe sagittal and coronal imbalance with a prior fusion. The MRI with central and lateral stenosis on the left side. Here you see vacuum phenomenon, instability, above fusion. So is there a role for MIS in a patient like this? Of course, you cannot treat this kind of pathology with an MIS procedure, but you can help creating a better correction by doing something minimally from the side. And especially at this point, I'd like to address the value of navigating the lateral aspect of the spine during the correction of a deformity. Because if you have a deformity and you're going from lateral through a small incision, like an X-lif or a D-lif, the anatomy you get is minor, and navigation, if you have it, is a great tool in order to feel more confident of bringing the right implant in the right direction without creating subsidence or having intraoperative problems. So it's not about getting nice images like this or blue and green cages. It's about controlling the correction you achieve from the side. So this is a perfect patient in order to use a minimal invasive technique, not to correct the deformity, but to help correcting the deformity with the minimal invasive help. This are the final images of the patient on the sagittal plane, coronal plane, and the construct again. So this was one patient that can benefit from an MIS procedure, and the second is like the patients that Vinny showed yesterday. This is a 64-year-old patient that has right-sided anterolateral thigh pain, no pain in sitting or lying, no back pain, and she had a prior decompression of foraminotomy at the L4-5 on the right side. And these are the images, and you see at 4-5, instability signs, a coronal deformity, sagittal deformity, and a big decompression at 4-5 on the right side. And she's still having pain, mechanical back pain, and right femoralgia from this operated segment. And if you take a look on the CT, the segments above the affected, the problem, are fused. So she has a solid fusion above and below the segment, and actually an instability on a priorly decompressed segment. So here you might go for it, but you're going for the pain, for the problem of the patient, not for the deformity. And there are very nice instruments we have on addressing this kind of pathology and minimally invasive, with this, give us options to distract and to see the whole anatomy, to put the screws without K-wires, even in very small pedicles. And these are images of the procedure, even navigating the cage, although I think navigating a TLIF is not so much of an issue, but it also gives you confidence that you're doing the right thing. And this is the final construct that leaves the patient in a deformity, but at the end solves the problem, which is the right-sided femoralgia. Incisions and the postoperative image. So I conclude that you might get benefit for an MIS procedure in trying to treat a deformity. You cannot solve the problem if your aim is to correct the deformity, but you might use, you combine MIS and open techniques in order to address this kind of problems. Thank you very much.